talk about ventilators, okay? We're going to talk about 10 things that every fellow should know before touching the ventilator, before even a resident should know. So we're going to go over, when you talk about ventilators, we talk about trigger, target, cycle. Trigger, limit, cycle. Trigger is what starts the breath. Limit is what is held constant during the breath. And then cycle is when it stops, okay? So you have volume control and you have pressure control. Volume control and pressure control are really both time or effort triggered. But let's look at volume control. It's either time, let's say it's 12 breaths per minute, so every 5 seconds there is a breath, or you could trigger it. If you go over here, you're causing a negative deflection here. This is a patient triggered effort. So that's trigger. Now the limit or target is what is constant throughout the breath. So as soon as the breath is initiated, you get 40 liters per minute or 60 liters per minute of flow. So it's flow limited, and then volume cycled. It knows to turn off after it gives you, let's say, 500 cc's. So let's say your ventilator is set at 12/500, 100% FiO2, and the flow is 60 liters per minute. So what happens is the time or the effort is triggered. The flow is 60 liters per minute, limited, and the volume, 500 cc's, is when it cycles. Okay, now pressure control has a same trigger, patient or effort, but also time. So let's say you don't trigger the ventilator. It's every 5 seconds or every 10 seconds, however you set it, like how many breaths per minute, you'll get the trigger. It is pressure limited because that's what's stable throughout the breath. As soon as you get the breath, you're getting a pressure that was given, let's say, of 25. And then the cycle is when time. So it knows to do the breath for, let's say, 5 seconds. I mean, it won't be 5 seconds, but however long the breath would be is dependent on time. Pressure support ventilation, just so you know, is flow cycled, meaning as soon as you stop the flow, that's when the breath stops. That's the difference between pressure support and pressure control. So once again, volume control, trigger, target, cycle, pressure control, trigger, limit or target, and then cycle would be time. Okay? And that's point number one. Point number two, assist control. So again, you set the flow rate, you set the tidal volume, you're guaranteed a minute ventilation. Okay, so this is assist control. The pressure will change breath to breath, but the tidal volume that you set is standard. Okay, so you could have somebody who has more and more stiff lungs for whatever reason, let's say pulmonary edema, let's say they're getting worsening ARDS. You give a standard tidal volume, the peak inspiratory pressure you might see is 26. The next day it might be 34. It might be higher the next day. So you have to check the plateau pressure, which we're going to go over. The vent has no plateau pressure alarm unless you set one. A rising PIP in volume control is the first sign that compliance is worsening. So one message I have for assist control is that, again, you set the flow rate, you set the shape, because it could be a ramp, or it could be a standard shape of the flow rate. You set a tidal volume. So a typical way to describe volume control, you should say rate, tidal volume, FiO2, and PEEP. So let's say you're on 18, 500, 100%, PEEP of 5. Okay, that's how you would say it. Airway pressure rises. That's the first sign that the compliance might be worsening. That is thing number two. Thing number three, pressure guaranteed. So when it comes to pressure control, you actually, if you notice, the flow is a decelerating flow. In volume control, usually it's a standard flow throughout the breath. Here, it's a little bit more comfortable for the patient, a descending flow pattern. You set the P inspiratory, you set the I time, inspiratory time. Again, that's going to be your cycle, and then your respiratory rate. The way to do it on most ventilators is you have an inspiratory pressure, let's say it's 20, a PEEP of 10. So that would be 20 plus 10 is the total pressure control of 30. That's how you add them up. On some of the other ventilators, I believe the Draeger ventilator, it adds it together. So if you wrote 25 and the PEEP is 10, that's actually 15 of inspiratory pressure on top of the PEEP, okay? So the pressure ceiling is, it's guaranteed. That's what the advantage of pressure control is. And in general, you want to set a low tidal volume alarm and monitor minute ventilation, because what happens is the pressure might be, let's say 30, but your tidal volume, you're not guaranteed. So for the same inspiratory pressure, you might get lower tidal volumes as the lung stiffens. And there's no alarm that fires directly unless you set a low tidal volume alarm. So that's one thing. So on pressure control, remember your volumes change depending on the compliance of the lung. You're not giving a tidal volume like you did with assist control, volume control. The hybrid is the pressure regulated volume control, which is more like PRVC AC, thing number 4 here. It's more of a pressure control breath. It's a decelerating breath. You set a tidal volume target, and the ventilator adjusts the inspiratory pressure 2 to 3 centimeters each breath to hit it. So let's say here is the P inspiratory pressure, the target tidal volume guaranteed here. You should know that the pressure often will creep up, masking worsening compliance. Sometimes you can't tell so easily that the compliance is worsening. So you just have to be mindful of what pressures the peak inspiratory pressure, because it might climb up as your compliance gets worse. But the way to remember PRVCAC is more of a pressure mode, because you get a decelerating flow of breath, and you're really giving pressures to target a tidal volume. Okay, so that's PRVC. APRV is not a rate in tidal volume, it's a pressure time profile. So you set a P high and a P low and a time high and a time low. Okay, what that does is basically you could think of yourself riding on a boat and opening up your mouth as you're riding a boat really fast, and you open your mouth and the air is coming in, and then all of a sudden you stop the boat. That's release ventilation. So when you're riding on the boat, opening up your mouth, that's riding the boat. And then when you stop the boat fast for just 0.5 seconds, that's release ventilation. That's when you ventilate. Okay, so it's basically extended CPAP, and you should avoid it in asthma or COPD. So this is time high. Let's say it's almost like pressure control. You don't want to get higher than, let's say, a plateau pressure of 30. So you set it at, let's say, 28, time low of 0. And then when it goes 4.5 seconds, you could still breathe on top of that P high, just like you would on CPAP at night when you're going to bed if you're on CPAP for OSA. And then time low, you get over there, that's the ventilation. You never get all the way down to 0, so that's where your PEEP plate, that's sort of your PEEP on APRV. So we went over assist control, volume control, pressure control, PRVCAC, and APRV. Now we're going to just talk about something you all need to know, P plateau and compliance. So this is on assist control. Your target plateau pressure is less than 30. What does that mean? That means that, let's say, here is PEEP, here is the peak pressure, okay, on the assist control ventilator. We're talking about assist control ventilation for now. You do a 0.5 second hold here. This is, let's say, half a second or even 1 second hold. Look what happens. You get the P plateau. You could think of the lung like a balloon. You inflate the balloon. If, let's say, you feel the pressure coming back at you after the full balloon is inflated, that is what we call plateau pressure. That's a measure of the stiffness of the lung. So if your peak is 36 and your plateau is 26, so we look for a difference of 10. Here it says, difference of 10. If it's less than 10, you think of that's okay. If it's more than 10, then you think of mucus plug, bronchospasm, and biting the tube. Okay, mucus plug, bronchospasm, biting the tube if it's greater than 10. This is on the cusp. If the plateau pressure is greater than 30, you think of stiffness of the lung. Okay, the other measure to look at is the plateau pressure minus the PEEP, which is what we call driving pressure, because that's where the lung, you could think of it inflating, that's plateau pressure, deflating all the way down to PEEP of 8. So there, the airway pressure difference is 18. That's not ideal. You want to target less than 15, okay? So you have a PEEP of 5. Peak inspiratory pressure, let's say, was 23. The plateau pressure is 20. That's normal. Compliance is the change in volume, which is 500 cc's, divided by the change in pressure, which in this case is the driving pressure, 20 minus 5, 15. So your compliance is 500 divided by 15, which is 33. This is a very key slide. You have to understand this. So the P plateau, once again, the target is less than 30. Compliance, we look for normal is 50 to 80, but that's rarely seen in a ventilator patient. ARDS may be less than 20. Really, you want to trend it, and you want to look at the driving pressure in less than 15. It's the best predictor in terms of lung stress and ARDS. And thing number 7. So we went over this. Plateau minus PEEP total is the airway driving pressure greater than 15 predicts ARDS mortality even after adjusting for low tidal volume and PEEP. That's the Amato trial in New England Journal of Medicine. So here again, if you have plateau pressure of plateau pressure of 26, a PEEP of 12, your driving pressure again is 14. Let's say you have auto PEEP of 2. Let's say you set your ventilator at 10, but your auto PEEP is 5, because you could check end expiratory pressure. That would be any additional PEEP. So that you actually add to the total PEEP. So you get it? So it's not, if you're set at 10 and you have auto PEEP of 2, really your total PEEP is 12. So the difference is 14. That would be okay. All right, that's a little trick there. But what I want you to take away, thing number 7 is driving pressure. Thing number 8 to remember is auto PEEP. What does that mean? So when your flow should go all the way back to the 0. If your flow doesn't go to 0 and you start the next breath, that will add air, that will add pressure actually at the end expiration. And that's called auto PEEP right there. That's what you would calculate. So you check an end expiratory hold, and then that can give you your auto PEEP. So PEEP was set at 10, but your auto PEEP is 5, so total PEEP is actually 15. So that you could check. It's often very hard if a patient's breathing very fast, but if they're completely sedated, you could definitely check, especially when they're paralyzed. It's the easiest time to check, and you press auto PEEP on any of the ventilators. The problem with auto PEEP is that it can increase your trigger threshold. Ineffective triggering, that's one of those causes. Of course, severe auto PEEP can cause cardiac arrest. That's when you would disconnect the ventilator. A fix would be to decrease the respiratory rate or increase the set flow rate. Never bag fast. Thing number 9. So if you want to know what dyssynchrony you have, you could always look at the flow pattern and you can get an idea of what is happening. And here is flow starvation. This is actually pressure versus time. So if you see a pressure curve and the pressure bows in early, that is flow starvation. So this is flow starvation. The easiest one to remember is that of double triggering. That's flow versus time. You could see here's the flow, and then all of a sudden you get another breath. Then there's ineffective triggering. You could see flow versus time here. You see flow, but you don't see a breath. That's auto PEEP. Here it's flow versus time, and you see that the flow never gets to 0. That's auto PEEP, and then reverse triggering is more rare. It's pressure versus time. You can see a little dip at the end of the breath. Sometimes for dyssynchrony, flow is used to look at it, and sometimes you could see it with pressure versus time. But the idea is that you should know the common types of dyssynchrony that you see on the ventilator. Double triggering, you increase the inspiratory time to alleviate that. Flow starvation, you'll just increase the flow. Ineffective triggering, you might have to deal with the PEEP, the auto PEEP, and reset them. Okay. So when to stop adjusting and call for help. So if your airway pressure, if your driving pressure goes above 15 and it's rising, you should really don't just blindly reduce the tidal volume. Find out why the compliance is worsening. Maybe there's pneumothorax, mucus plugging, new infiltrate, worsening ARDS. If the patient's fighting the ventilator, yes, you're probably going to sedate, but is it dyssynchrony? Is it bronchospasm, pneumothorax? Remember the change in pressure, peak minus plateau. If it's greater than 10, mucus plug, bronchospasm, biting the tube. If the plateau pressure is greater than 30 and the difference isn't greater than 10, then you think of worsening stiffness in the lung. Sometimes you could have a right main stem intubation. Sometimes you could have pneumothorax. Auto PEEP and hemodynamic instability. You could disconnect the ventilator, allow full exhalation. Refractory hypoxemia, despite optimization, you might want to prone, you might want to confirm or consider a neuromuscular blocker, and you might want to call for ECMO. If you've adjusted the vent twice in 30 minutes and the patient isn't better, that's when you need to call the attending. An event that needs constant tweaking is telling you something is wrong. So in summary, the 10 things we went over: trigger, target, cycle. We went over assist control, ventilation. We went over pressure control, understanding that tidal volumes will change with pressure control. We went over PRVC, which is like pressure control. We went over APRV. We understood what peak and minus plateau is and what driving pressure is. And then we went over auto PEEP. We went over some dyssynchrony ideas: flow starvation, double triggering, ineffective triggering, auto PEEP, reverse triggering, and then some pearls when to call for help. Hope you enjoyed.